Thank you very much, and thank you to all the invited speakers who kept to their time. That now transition to the contributed abstracts. And our first presentation will be Dr. Rui Shen from Tsinghua University. Will be talking on atherosclerotic plaque characteristics in extracranial carotid artery, may indicate closer association with white matter hyperintensities than intracranial arteries.
Okay, thank you for a brief introduction. Good morning, everyone. And my name is Rui Shen from the Tsinghua University. It is my pleasure here to share my research. And the topic of my report is the atherosclerotic plaque features in carotid artery may indicate closer association with white matter hyperintensities than intracranial arteries. And several vascular diseases were investigated to be the main causes to the death of human beings in the world. And when we compare the leading causes ranked in China and in the USA, the cerebrovascular diseases come to the top 5 range, and morbidity and mortality caused by the cerebrovascular diseases have spread all around China. And in many previous studies, the cerebrovascular diseases can be divided into 2 subgroups, including the large vessel diseases and small vessel diseases. And these clinical signs of brain impairment include ischemic stroke, white matter hyperintensity, and so on. And in our study, for white matter hyperintensity, the Fedekes score has been proposed to evaluate the severity of white matter lesions. And some researchers reported that the atherosclerosis is significantly associated with white matter lesions, both in intracranial arteries and extracranial carotid arteries. For atherosclerosis, it may occur with the demonstrated region of intracranial arteries and extracranial arteries. And beyond the carotid artery stenosis, plaque compositional features in carotid artery were reported to be significantly associated with the severity of white matter hyperintensities. And meanwhile, the investigators also found that the intracranial atherosclerotics is associated with the intracranial arteries plaques. Among the intracranial and extracranial carotid arteries, it remains unclear that the atherosclerotic plaque features in which vascular bed are more closely with the WMHS. Since then, we conducted this study, and this study recruited patients in CARE 2 study with the demonstrated including and excluding criteria. And the MR imaging was performed with a 3D MR scanner and includes carotid vessel wall imaging and MR brain imaging. Since then, after the acquisition of MR images, the arterial stenosis, compositions of carotid plaque, and white matter lesions severity were evaluated according to the nascent and Worthy criteria and Fedekes scores. And in this study, the white matter lesions severity with Fedekes scores was divided into 2 groups, which are a group with score under from 0 to 2, and another group with score larger than 2. And in a statistical analysis, comparison was conducted to determine the differences of clinical characteristics of arterial atherosclerotic features between patients with and without moderate to severe WMH. And also univariate and multivariate regression were conducted to determine the discriminated value of AS plaque features of intra and extra artery for moderate to severe WMH. And here is the population flow chart of our study. And then here we can see the clinical information of all the patients between 2 groups. And we can find the age, sex, BMI, and these demographic information as the reference mentioned before is associated with have differences between these two groups. When we compare the atherosclerotic features of carotid and intracranial arteries, we can find the luminal stenosis and the presence of calcification, LRNC, IPH, and FC is significantly different from differences between these two groups. And also when we compare, when we conduct the univariate and multivariate logistic regression, we can find the most features of the carotid arteries are significantly associated with the WMH. And after adjustment of the clinical information, we can find only the calcification and LRNC are the independently associated with the WMH. Since then, we can, according to our results, we can have the discussion about like this. And firstly, the patients with moderate to severe WMHs were more likely to have higher grade stenosis and prevalence of carotid plaque composition features compared to those without. And also the carotid calcification was independently associated with moderate to severe WMHs. And we can also see when we based on the previous studies that the clinical information is more associated with the white matter lesions. Since then, we can conclude that the association between atherosclerotic plaque characteristics and severity of WMHs was not found in intracranial artery, which is controversial with the previous studies. And maybe it's due to the vascular bed which enrolled in our study. We just enrolled the posterior arteries of the patients. And since then, we can indicate the large artery atherosclerotic plaque features in extracranial carotid artery may have closer association than with severity of WMHs compared to intracranial artery atherosclerosis. And since then, there are still some limitations of our study. First, the population is not of the recruited vascular bed is not very the whole brain, mainly in the posterior vascular. Since then, we need to enroll more vascular analysis. Secondly, our study need to conduct follow-up study to investigate the causal relation between the atherosclerosis and the white matter lesions. And that is all. Thank you.
Thank you very much for your interesting presentation. The paper is open for questions. Anybody from the floor, please come to one of the mics. I could start off with a question. So you show a correlation with calcification. Do you have any ability to quantitate how big the calcification is? Is there a correlation with the amount of calcification? And then a second quick follow-up, do any of your patients also have CT studies that might be more sensitive to identifying the calcification?
Okay, thanks for your questions. I think the first question is the calcification volume. Yeah, in our study, we cannot, maybe in the further study, we can measure the calcification volume. But now we haven't measured it and evaluate the relationship between calcification volume and the white matter lesions. And second question, I think in our studies, this study population comes from the CARE2 study, which have been conducted before, and we have not conducted the CT examination. So maybe in the future, when we conduct the follow-up study, we can add the CT examinations. Thank you.
Kind of a follow-up to that one. Sorry, over here. So you just did presence, absence of calcification. Did you look at morphology at all by any chance? Or like where it was relative to plaque?
Do you mean the relationship between the plaque and the calcification?
Like where it was in the plaque?
Where
Or
in the plaque?
Yeah.
You mean the calcification location in the carotid plaque?
Yeah, like if it was more along the like the luminal surface, was it along the adventitia, and then like, did you look at any sort of morphology?
In our study, we haven't investigated the location of the calcification, but I think the calcification location is the maybe a risk factor for the vulnerable plaque. Yeah, but in the future, I think for further investigation, it is necessary to both investigate the location and the volume of the calcification with the wet matter lesions, I think. Thank you very much.
Thank you. We'll move on to our next presentation, which is from Qingli Kong, who is presenting from the University of Southern California on interleaved flow-sensitive dephasing for enhanced blood flow suppression and preserved T1 weighted contrast. And I see our presenter is Xiaoyang Fan.
Thank you, David. Unfortunately, Dr. Kong cannot make it, so I will be giving this talk on his behalf. So it's my great pleasure to introduce a new blood flow suppression technique. So as you know, T1 weighted 3D turbospin echo sequence has been broadly used for many different neural applications. For example, arterial reservoir imaging, cerebral venous sinus imaging, and brain tumor imaging. So because a lot of attractive technical features, such as superb signal-to-noise ratio, acquisition efficiency, and the intrinsic black blood effect, and a high voxel isotropy. So the primary, the inherent blood flow suppression is actually the most important feature of this technique. The primary mechanism is due to the intravoxel dephasing of moving blood spins, and also the cancellation effect due to the simulated echoes. However, this effect is more effective for relatively fast blood flow, or when the blood flow is aligned with the frequency encoding direction, radial direction. For example, in this example, you can see when the flow is perpendicular to the radial direction, or when it is too slow, like turbulent flow in the aneurysm, or the flow is in the intracranial sinus, is pretty slow. So the flow suppression is not really enough. That's why you need either realign the flow suppression to flow direction to the radial direction, or you can utilize some extra blood suppression module. So that's why several extra blood flow suppression module has been proposed, such as MSDE or FSD module, and later DENTE module. However, based on our experience and literature, we found out these two typical flow suppression module can lead to lower SNR or lower T1 weighted contrast. And more importantly, we realized that both modules have dead angle for blood suppression, which actually has been demonstrated 10 years ago when we work on the non-contrast MRA. As you can see, when you apply the gradient in X and Y direction simultaneously, you actually have a single direction flow sensitivity. And that's why when we do the subtractive MRA, you can see the flow in this tube has been effectively suppressed during the FSD acquisition. That's why after subtraction, you can see this flow. But the flow in other perpendicular tube is not essentially suppressed. So in this technique, we propose interleaved flow suppression dephasing module. And the idea is to, based on the commercial 3D TSE sequence, or we call the SPACE by Siemens, and we actually add one 180-degree refocusing pulse between the excitation and the originally first refocusing pulse. And we added a pair of unipolar FST gradient pulse around the 180-degree alpha pulse in both phase encoding and partition encoding direction. So the idea is we just rely on the inherent flow suppression in the readout direction. Now we just want to introduce extra flow suppression in phase encoding and partition encoding direction. And the polarity of the FST gradient in the phase encoding is toggled every TR, so that we can really generate cumulative first gradient moment in orthogonal direction. So we start with the flow phantom study, try to demonstrate the interleaved FSD is more effective than regional FSD the MSDE or Dante sequence. And we just use a fixed flow first gradient moment in each axis. And then we perform a in vivo study. First, we start with 6 healthy volunteers to try to optimize the first gradient moment. And then, based on the 8 healthy volunteers, we want to really compare the 4 different sequences with quantitative assessment, such as flow suppression measured by the venous sinus SNR, brain tissue to sinus CNR. And also for T1 weighted contrast, we measure the gray to white matter CNR, and for overall signal, we measure the white matter SNR. So here, please note that we measure the signal in the venous sinus because the flow here is pretty slow. So in healthy volunteer, we can really utilize this location to measure our suppression capability. So here's the phantom study. You can see when we just try original MSD or FSD space sequence, we can suppress flow in this short axis part, but in long axis part, let me go back to here. So we have a long and short axis part. So this original FSD module or MSD module cannot really suppress the flow in the perpendicular part. However, with IFSD, we can cover both segments. And in a healthy volunteer, you can see the conventional 3D TSE. We can see the blood signal, residual blood flow artifact in both sides in the transverse sinus. And with the conventional MSD or FSD TSE, we can see this sequence can really take care of the left side sinus. But this right side is really not fully suppressed. But with FSD, we can take care of both sides. And this is a flow phantom study when the flow at different velocities. As you can see, when the flow is pretty fast, all sequences give you very good flow suppression. And when the flow becomes slower, the conventional TSE is becoming incapable. When the flow is pretty slow, so even the Dante and MSD sequence are not enough, and the FSD can really suppress flow completely. And based on the healthy volunteer, we optimize M1 as a 400, first gradient moment of 400 per axis. So this is based on the balance between blood suppression and preserve the T1 weighting. And based on the volunteer study, we compare the 4 different sequences. As you can see, there's no difference in the sinus SNR among the Dante, MSD, or FSD TSE sequences. But the FSD TSE really show the best blood tissue to sinus CNR among the 4 sequences, which suggests the superb black blood effect. And also FSD TSE yielded the highest gray white matter CNR compared to Dante TSE or MSD TSE, but slightly lower than TSE, which suggests a superb T1 weighting. And also we found the FSD TSE give you the higher white matter SNR compared to Dante and MSD TSE, but slightly lower than TSE, which suggests a superb overall SNR. So let me just give you a few clinical examples. This is an example in the healthy volunteer, actually. We can see the pre-controlled TSE, that you won't see any residual flow signal clearly, but once you give a contrast agent, you see several bright spots, especially in this one, which is very close to the middle cerebral artery, and which can really be confused as a contrast enhanced plaque. But with our FST, we can suppress all the bright spots. This example in aneurysm, so let me show you the zoom in image. So pre-contrast TSE, and this is all the pre-contrast different sequences. You can see original TSE shows some residual artifact, and Dante TSE a little bit, and MSD a little bit. But the FSD is comparable with the conventional MSD TSE. But when you give contrast agent, you can see the FSD can really suppress the residual flow signal very well. And this is an example in the AVM. And as you can see, FSD can suppress the flow signal completely, which can really help identify the volume of the AVM. And this is a last example in the brain mets, which is different from the previous vascular study. But I realized that this flow suppression is also very important for brain mets, because the radiologists always rely on identifying the bright spot in the brain. So with conventional TSE, you will see a lot of enhancing lesion, but which are not actually a lesion, which can be shown by FSD TSE. So in conclusion, FSD TSE is a promising 3D TSE imaging technique with enhanced blood suppression and preserve the T1 weighted contrast and overall SNR. And our preliminary results show the great potential of this sequence in imaging vessel wall disease and brain mets. And we are actually conducting a study to systematically investigate the performance of this new technique in various diseases. And I would like to thank our funding support, and thank you for your attention.
Thank you very much. Very exciting and promising results. Unfortunately, following the guidance of our organizers, you used up your time on your talk. Okay. So I will look for you in the break to ask questions. We'll move on to the next presentation.
Thank you.
So our next presentation will be Long Yang from Shenzhen Institute of Advanced Technology, speaking on a flexible automated vessel center lines extraction and vessel segments labeling method to assist plaque detection and evaluation.
Hello everyone, good afternoon. My name is Yang Long, and I am from SIAT, Chinese Academy of Technology. The title of my presentation is Flexible Automatic Vessel Center Line Extraction and Vessel Segment Labeling Method to Assist Plaque Detection and Evaluation. According to the statistics of WHO, the vessel-related disease, for example, ischemic heart disease, and stroke, are the top two leading cause of the death globally. And the number one is ischemic heart disease. It is about 9 million. The second two is stroke. It is about 6 million. The abnormality of vessel and the surrounding tissue are closely related to vessel pathological events, for example, such as the stenosis and plaque and aneurysm. Vessel centralized extraction and labeling is the first and important step for further abnormal analysis. Because that if we directly observe the image in a 3D image, it is very hard because we need to move the image and rotate the image for to observing the tissues around the vessel. So after finish the centralized extraction, we can focus on the area around the vessel and do the morphological analysis and the analysis of the vessel lesson and so on. Doctors usually manually extract the central line and determine the segment of the vessel for observing surrounding tissues for further analysis. However, this process is time-consuming. And also in some cutting-edge research, many centralized extraction of the vessel is also a limiting factor in pipeline of automatic vessel analysis. And there are some related words. The number 1, number 2, and number 3. The expandable skeletonization algorithm, and number 2, region growth algorithm, and number 3, minimal cost function. There are some traditional methods. The limitation of this traditional method is that it those contain some manual method. For example, we should point a manual start point and a manual end point for and so on. So recently, some research used the convolutional neural network to do that. But in the paper, it is used for MRA. The centralized extraction in MRA is easier compared with the centralized extraction in black blood MRI. I had used to directly input the 3D MRI to the CNN model, but the connection of the centralized is not very good. It is not good due to the force of some layers, and so in this way, also the blackboard MR reservoir image can be directly image reservoir for observing plaque. There is still a lack of vessel centralized extraction method for MRVWI. In this way, we propose a method for centralized extraction. The method is can be divided into 3 steps. The first step is that segment the main vessel segments and extract the central line of the vessel. You can look at that. The inputs can be blackboard MRI and bright blood MRA. And then we put the image to the deep learning model. It is a improved VNet model. We just add some unit as a module to the VNet and change the structure of VNet. Then then the model will output a vessel prediction. After we got the vessel prediction, we can use the distant field method to extract the central line from the vessel. So, the main step is that input the image and use a deep learning model to get the vessel. Then we use a graphic method to extract the central line from the prediction. The step 2 is that ensure the connection of the central line, because the connection of the prediction is not good. So we use another model to extract another vessel. The difference is that in step 1, we extract the vessel and we segment the vessel and extract the centralized is 15 segments. It is labeling. It contains a labeling step. But for the step 2, we just use a binary mask to tell the model that you just need to segment. You just need to segment the vessel, and you don't need to labeling them. So it is not difficult like the step 1. And that's why it's tried to centralize, because we want to use the second step to collect the first step. Finally, we use the second centralized and neighborhood position algorithm to detect and correct the position errors in the bifurcation of the first centralized. First, we can transfer to determine whether there is a bifurcation point and combine the angle to determine whether the point is correct. For example, it is a sample. How to determine whether the green point is correct bifurcation point? We are human, so we can directly find that the green point is not the bifurcation point. But for the computer, they don't know that. So the first step is that we find the point, the neighbors of the point is different. For example, the green point, his neighborhood is different. His neighborhood is red. So it is the step 1. If y this point, when we find the point, we put it to the waiting pool. After that, we calculate the neighborhoods of the point in the waiting pool. For example, we calculate this one point. For example, we calculate this point and this point. The angle of this point and this point is about 118. And then the angle is similar to the 1018. So we can ensure that it is not a bifurcation point. But if the point is in here, we can find that his neighborhood, this one is his neighborhood, and this one is his neighborhood. We calculate this one point. We calculate the angle in between this one and this one. The angle is not close to the 1018, so this one can be classified as the bifurcation point. Okay. Overall, the proposal method for centralized extraction mainly consists of their 3 steps. The first step is we extract a multi-label centralized, and the second step is that we use the deep learning method to extract the binary centralized, and then we use the binary centralized to create the multiple centralized, and we use the graphic method to create the final centralized. The result is that we can find the proposal method achieve average completeness of 95% for the centralized extraction and labeling of 15 vessel segments in an average time of just 0.49 minutes, with an average surface distance of 1.251, which is very similar to the ground truth. And we use different input. The number one is use the MRA to assist the MRI. The the performance is best. For the brief summary is that vessel-related disease is serious threat. So, and central extraction is an important step for disease analysis. And next is that we use the deep learning model. It is used to segment vessel, and graph methods are used to extract and create the centralized. And number 3 is that flexible input is acceptable, and the best result can be achieved when there is a bright broad image to assist with the black board image. Thank you.
Thank you very much. Again, unfortunately, we've run long on this, so it looks like a very interesting technique, but I think we'll have to move on to the next presentation. And I'd encourage all the speakers to try and leave some time for questions so that we can have an interesting discussion about their interesting work. The next presentation will be by Shuan Yu, who's also from Tsinghua University, talking on signal intensity of carotid artery perivascular adipose tissue on MR imaging.
Hello everyone, I'm Shu Wanyu from the Center for Biomedical Imaging Research of Tsinghua University. My topic is signal intensity of carotid artery perivascular adipose tissue on MRI, a potential indicator for carotid vulnerable atherosclerotic plaque. It has been shown that inflammation of perivascular adipose tissue, which is called PVAT, is associated with atherosclerotic disease. Biological studies have confirmed that due to the complex bidirectional interaction between the arterial vessel wall and its corresponding PVAT, the inflammation of PVAT is closely related to vulnerable plaques. As we know, MR imaging has the potential in assessing the inflammation of perivascular adipose tissue due to its excellent soft tissue contrast. However, there lacks evidence for the association between carotid PVAT measured by MR imaging and vulnerable plaques. Therefore, the study aimed to investigate the association between signal intensity of PVAT and vulnerable plaques in carotid arteries using multi-contrast MR visual imaging. In this study, a total of 104 patients with moderate to severe atherosclerotic stenosis referred to carotid endarterectomy were recruited. The mean ages of the patients were 35 years old, and 86 men were included. All patients underwent bilateral carotid multi-contrast MR visual imaging, including TOF MRA, T1 weighted, T2 weighted, and SNAP sequences. The imaging parameters were listed in this table. Our imaging acquisition plan was transverse, and the fat saturation technique were applied to T1 weighted and T2 weighted imaging sequences. The MR visual images were reviewed by 2 experienced radiologists in neurovascular imaging using custom designed software with consensus. As shown in the figure in the left, the plaque comments of calcification, lipid-rich necrotic core, intraplaque hemorrhage, and loose matrix was identified according to the published criteria. In addition, presence of intraplaque hemorrhage, fibrous gap rupture, or lipid-rich necrotic core with an area ratio of more than 40% to the arterial wall were considered as vulnerable plaque features. The T1 weighted images were registered with TOF images using elastic turbos. The outer boundaries on TOF MRA were also magnified 1.5 times, which will be considered as a region of interest. According to the fast separation of T1 weighted imaging, and the difference in signal intensity between tissues. A K-means clustering algorithm was used to automatically segment the fat mask on T1-weighted images. Crowded PVAT was identified as a fat component within the region of interest. The signal-to-noise ratio and the contrast-to-noise ratio at each slice on top images were calculated. In addition, Mann-Whitney test and generalized linear mixed models were used for statistical analysis. In this study, the SNR and the CNR of crowded PVAT were compared between slices with and without plaque comments. The results show that crowded artery slices with vulnerable plaque features, particularly intraplaque hemorrhage and fibrous scab rupture, had significantly higher SNR or PVAT on top MR images compared to those without, where such differences were not found on CNR of PVAT. Then to generalize linear mixed models were established to explore the association between SNR or CNR or PVAT and plaque comments respectively. The results show that after adjusting for clinical confounding factors, the SNR or PVAT was significantly associated with presence of intraplaque hemorrhage and vulnerable plaque. However, no significant association was found between the CNR or PVAT and the presence of vulnerable plaque features. Previous studies have confirmed that density of crowded PVAT on CTA was associated with crowded vulnerable plaque features, particularly intraplaque hemorrhage, which is consistent with our findings. Moreover, our study was the first to investigate the relationship between crowded PVAT measured by MRA and vulnerable plaque features. In conclusion, the SNR of crowded PVAT on top of MRA was independently associated with vulnerable plaque features, suggesting that the signal intensity of PVAT might be an effective indicator for vulnerable plaque. However, the CNR of PVAT might not be a potential indicator for vulnerable plaque features, suggesting that using muscle signal intensity as a reference may counteract to some extent the inflammatory changes in PVAT associated with atherosclerosis. The present study also has several limitations. First, there is no unified definition of PVAT. Second, the accuracy of crowded PVAT segmentation might have been affected by the fat separation technique of T1-weighted imaging. Third, the saturation effect of top MRA might have a potential impact on fat signal. In the future, quantitative fat imaging techniques such as Dixon can be used for determining the inflammatory status of PVAT. Finally, a larger cohort with broader range of stenosis should be included in future studies. That's all for our research. Thank you for your attention.
Thank you very much and for keeping in time. So this paper is open for questions. Anybody? Dr. Zhu.
Yeah, very nice talk. Can you comment on the application of the finding where you see the perivascular fat is an indicator of vulnerable plaque, but you already perform MRI, you can directly see the plaque already. So what's the application of this finding?
Okay, thank you very much. That's a good question. Firstly, our research finding that the signal intensity on top of MRA is associated with vulnerable plaque features. This finding helps us to better identify the vulnerable plaques. What's more, secondly, we can we can join to the maybe we can join to the vulnerable plaques and the inflammation of PVAT to prediction prevent the carotid disease such as stroke. Yes.
Do you think that can be an additional imaging marker coming in addition to the plaque features, the perivascular fat information?
Oh yes, I think maybe in the future it will be a good marker to for the vulnerable plaque features. Previous studies identify the inflammation of PVAT on CTA, but CTA can't to directly to identify vulnerable plaque features. Well, TOF MRA can directly identify the vulnerable features. At the same time, we can evaluate the PVAT inflammation on MR imaging. This will help us to explore this association between PVAT and vulnerable features. And our study have confirmed that the inflammation of PVAT on top of images is a good indicator for vulnerable plaques.
Yeah, thank you.
Thank you very much.
Thank you very much. We'll move on to the next presentation. Rita El Sayed from Emory will be speaking on black blood wall imaging is superior to time of flight for the visualization of carotid webs.
Thank you. Thank you everyone for coming, and my name is Rita, and I am a fifth-year PhD student at Emory University, and I'm working under Dr. John Oshinsky and Jason Allen. Today I'll just be talking a little bit about my work in regarding to black blood vessel wall imaging in patients with carotid web. And I just have one disclosure. We do have a grant with Siemens Healthineers to support this work. So a little bit about black blood imaging, or a little bit about carotid webs. Carotid webs are shelf-like or pyramid-like projection in the internal carotid artery, as we can see here in the CTA image. It doesn't cause severe luminal narrowing. It causes very mild luminal narrowing, up to 50% European, according to the European trial. And it's not atherosclerosis lesion. It doesn't have any inflammation. It doesn't have any plaque or vulnerable regions. Carotid webs have been linked to cryptogenic strokes in younger patients, and we believe that up to 1/3 of cryptogenic strokes actually account due to carotid webs. And the age difference between a patient with an atherosclerosis or a carotid web patient is actually pretty big. Usually atherosclerosis affects older people, and here I have my population, which is between 60 to 80 years old, while patients with carotid web is around 40 to mid-40. And we believe that carotid webs, actually, the shape of it causes this hemodynamic disturbance in the flow profile. So there is some recirculation and stagnation leading to some image artifact. And here we believe that this recirculation causes this a clot, or the blood to clot here, and then causes a stroke downstream. And we know this because we have some DSA scans that we can see some blood pooling in the carotid bulb. And so the mechanism here is that there's some flow coming, there's blood flow, parabolic blood flow coming in, there's acceleration at the tip of the web, and then we see there's some recirculation regions, some reverse flow, and some flow separation. And we know that this is the region that actually where the clot might form, because we do have we were lucky actually to capture some of these clots on CT. And why I'm talking about this, I'm very interested in studying the flow. And so if I want to use 4D flow for this specific application, I need some good vessel wall image. And in our standard protocol, we usually acquire time of flight images, but in these patients, actually the flow or the signal loss in time of flight images is really bad. So we can see that there is a very big signal loss here is due to that flow stagnation and separation. And this is the same patient, I'm just showing the CT of it. So this leads me to the aim of my talk. And so I'm trying to evaluate the effectiveness of vessel black blood imaging in comparison to CT and 3D time of flight in these specific patients. So we have recruited 10 subjects with carotid webs. Most of them are female, early to mid 40s. They have mild luminal narrowing, around 30%. And a history, all of these subjects actually came to our attention because they had a symptomatic carotid web, so a history of a stroke or a TIA. And so we scanned them on our 3 Tesla system at Emory University, and we decided to acquire a time of flight image, and you can see there is some separation in this image. And then black blood vessel wall image, and here we have 2 different protocols. One star match, which is a Siemens developed, and then T1 space is also Siemens developed, but T1 has a little bit of a better resolution. And finally, our CT. So CT, all these patients actually had CT because they came to our attention because of they developed a stroke or a TIA. So for the time of flight, as you can see, it's really hard to segment the web. So we came up with this thresholding method between the lumen and the background, and we decided to see the area. And as you can see, there is a little bit of overestimation. And then for the black blood vessel wall and CT, we did the segmentation manually. So here I'm showing the web volume. I'm comparing the time of flight, CTA, and black blood. And as you can see, black blood actually gave us a very nice comparison to CTA. So we can see the web very, very nicely on black blood compared to CTA, very comparable. And the volume actually, in some images, in this specific patient, actually, we saw the web way nicer at the black blood compared to the CT. Time of flight, I don't recommend using it here because there's this really big overestimation in the region. So finally, the black blood imaging with star match is very comparable, or T1 space is very comparable to those with a CTA scan. So actually, I've been using some of these vessel wall segmentations for my 4D flow processing, which is going to be later this evening. And then the comparison to a 3D time of flight was statistically significant. So 3D time of flight is good for specific applications, but when you have a very complex blood flow, I don't believe it will give us the right geometry. And the overestimation of 3D time of flight is due to that complex flow patterns. And thank you all for listening. I'm happy to take any questions.
Thank you very much. Paper's open for questions. While we're waiting for questions, I could ask one.
Mm-hmm.
Very nice demonstration on the black blood, but we know that in many cases these webs are not just shelf projections, but are cusps. Mm-hmm. So you can have, as you indicate, slow recirculation, and in black blood, as Dr. Fan showed, we get artifacts in that case and poorer delineation. Have you considered using contrast-enhanced MRA to fully delineate the lumen?
Yes, so actually contrast-enhanced MRA is something we've been trying to get to Emory, and we've always like asking if we can get a little bit of a better MRI images. But at this point, we haven't actually tried it in this specific patients. All of these are non-contrast enhanced.
If there are no other questions, I'll ask a follow-up. Have you tried 4D flow in these patients with webs?
Yes. So my talk at 4 p.m. will talk a little bit about the 4D flow and a little bit of the quantitative analysis that we did. So we did a bunch of little stuff here and there.
Look forward to it.
Thank you.
If there are no other questions, thank you very much, and we'll move on to the next presentation.
Thank you.
The next presentation is from Jinhua Dong, also from Shenzhen Institute of Advanced Technology, automatic carotid plaque segmentation with multi-head loss based deep learning model.
Hello everyone, my name is Yang Long. The Jinhua Dong is in Shanghai, and it is he is busy, so I do this presentation. I'm great to here to share our research for the PRAQ segmentation. This study is used prior knowledge to assist the PRAQ segmentation. For the background, stroke is second leading cause of death worldwide. From the statistics of WHO, WSO, World Stroke Organization, there were 3.48 million people died in 2020 due to the stroke, ischemic stroke. It means that one people die every 9 seconds. PRAQ, especially vulnerable PRAQ, is considered as an important predictor and correlation of ischemic cerebral events. Therefore, assessing PRAQ progress and stability is crucial for the prevention, monitoring, and the treatment of ischemic stroke. For the vulnerable PRAQ, rupture is secondary to thrombosis. It's the main pathogenesis of the ischemic stroke. We can, for example, we can image that if there is a big vessel and there is a small vessel or a vessel with narrow. If a plaque occur in the big vessel, and the plaque was correct, so the plaque will follow along with the vessel and align the small vessel or align the narrow of the vessel. Then the plaque will block the area of the small vessel. In this way, the stroke will happen. High resolution MR reservoir image is a high resolution, no invasive, accurate method for quantitative evaluating PRAQ that provide details information on PRAQ morphology and composition. Research can quantitatively evaluate PRAQ based on MR reservoir image to assess its risk, monitor PRAQ progression, and evaluate the therapy effects. This is the cross-section image of the tissues with the PRAQ. The green area is the reservoir. The lumen area is the lumen. The PRAQ is in the reservoir. the pressure is only in the reservoir. So the segmentation of pressure is the basis for further quantitative analysis. However, pressure segmentation is in the large scale image is difficult because it requires experienced professional radiologists and significant time and labor costs. And many operations often face issue of bias and repeatability, which affect the timelines and accuracy of risk assessment. So it is necessary that develop an automatic and accurate method to finish that. The pipeline of the method is that we input MR image to the deep learning model, just like I tell about, do the centralized extraction, and then we capture the cross-section image along with the centralized. So in this way, we got the input image. We input the image to the deep learning model, and the deep learning model will output pressure, lumen, and reservoir prediction. And then we use the prediction to do the quantitative analysis. For example, we can calculate the area of the lumen, the area of the reservoir, and pressure. And we can use, after we got the area data, we can use that to calculate the Stanley's rate and others quantitative indicate. So this study is focused on the pressure segmentation. At the beginning, we address improve VNet to do this work. The dice similarity coefficient is about 0.73. We add some CBAM attention model. CBAM is the convolutional block attention model, and we add the residual UNet. We adjust the structure of the VNet, and then finally we got the 0.73. But I don't think it is a good result for clinical demand. It can't satisfy the clinical demand. So we analyze the reason that the difficulty of pressure segmentation is that the pressure is small and the boundary is unclear. So how to solve this problem? How to overcome this difficulty? The response strategy is that we add a prior knowledge to the model. Tell the model that the pressure and the vessel is here. You just need to classify the pressure from the reservoir. The special operation is that we input the reservoir mask and MR image at the same time to the model. The model, in this way, the model know the location of the pressure and now the morphology of the model. In this way, the performance is improved. The dice increase from 0.73 to 0.83. Have we finished there? No. Because the input still require the time-consuming manual mask of the reservoir. We should input the manual mask of the reservoir to the model. So in this way, we develop another model to segment the reservoir, and then input and then combine the image, combine the MR image and the reservoir prediction to next model. In this way, the whole pipeline the whole process is automatic. but the performance is not very well. So we think that the automatic prediction of vessel wall pre-op may not be perfect, which can affect the second model prediction of the PRECU. Moreover, the two models are independent and cannot optimize based on the final goal. The final goal is PRECU segmentation. So in this way, we develop a one-step method. It means that we we use the mask of lumen, vessel wall, and PRECU in one model. When the model training, they will know that where is the lumen, where is the vessel wall, where is the PRECU. In this way, they can optimize the PRECU segmentation. The dice increase to 0.182. It is similar to the manual mask. So the pipeline become automatic process. The detail is that we write three loss. The first loss is central loss. The central loss is the whole vessel. The second is the multi-level loss. The loss contain the vessel wall and lumen. And the three loss is the PRECU. In this way, the optimization objective is the PRECU binary loss in the growth truth of PRECU. So a brief summary is that after multiple improvement, the method of pre-op automation can now achieve good results. I summarize some steps of the development of the pre-op knowledge segmentation. The first is that in 2020, some research used the boundary box to segment the PRECU in the ultrasound image. But I don't think it is a good method because the boundary box need to it is a manual step and it is not very accurate. And then we use the manual pre-op to help to assist the PRECU segmentation. The next, we change it this way to the automatic method. Finally, we use multi-head loss to got a good performance. Finally, is the
maybe you can just move to the conclusion now, please.
Oh, okay, thank you. Okay, actually, this all. That's all. Thank you.
Thank you very much. So the next set of abstracts will be moderated by Dr. Chow.
Thank you. So now our next speaker is Dr. Li Yan, and he's from department from Tsinghua University, and she will present aneurysm wall permeability in detecting high-risk non-circular intracranial aneurysm based on DCE MRI. Thank you.
Thank you. Hello, everyone. My name is Yan Li from Tsinghua University. Today I will introduce my work about aneurysm wall permeability in detecting high-risk non-circular intracranial aneurysms based on DCE MRI. I have nothing to disclose. Intracranial aneurysm, IA for short, is a common vascular disease affecting approximately 3.2% of the population. Aneurysmal subarachnoid hemorrhage, SAH for short, has a mortality of approximately 50%, with survivors incurring a tremendous personal and financial burden due to permanent disabilities. Although prophylactic treatment of surgical intervention can effectively prevent aneurysm rupture, patients also need to bear the risks and complications of surgery. Therefore, an effective assessment of IA rupture risk is crucial. IA can be classified as circular and non-circular, with non-secular category further divided into fusiform and dissecting aneurysms. Recent investigations have proposed wall permeability as a significant predictor for rupture risk in secular IAs. However, there exists a substantial divergence in the pathological structure and shape between secular and non-secular IAs as illustrated in the table. Therefore, this conclusion may not necessarily be applicable to non-secular IAs. Therefore, our study seeks to predict non-secular IA rupture by wall permeability calculated from the dynamic contrast enhanced magnetic resonance imaging, DCE MRI for short. 16 patients with unruptured non-secular IAs diagnosed by CTA, DSA, or MRA were included in the study. Exclusion criteria were first, pregnant or breastfeeding women, and second, any contraindications to MRI. This table shows the demographic and clinical information of their patients. In this study, we utilized a clinical 3T MR system as our MRI scanner with a 32-channel head coil serving as the coil. 3D black blood T1-weighted volume isotropic turbo spin echo acquisition, VSTAR for short, were used for capturing pre- and post-contrast aneurysm wall images. 3D T1-weighted spoiled gradient echo sequences were utilized for obtaining DCE MRI images. For DCE, the contrast injection rate, number of slices, and time resolution are listed here, and other parameters of VSTAR and DCE are shown detailed in the table. For imaging analysis, we firstly assess that the aneurysm is non-secular by analyzing multiple sequences. From the 3D images, we can observe that the aneurysm is non-secular, and the pre- and post-contrast images show that this aneurysm is fusiform. Key trends were derived from the extended Kathy-Tops model based on DCE MRI, where key trends represents the transfer rate of contrast agent from the intravascular space to extravascular space. The plasma contrast agent concentration, CP for short, and the contrast agent concentration in the tissue surrounding the aneurysm wall, CT for short, is manually delineated, so we can get CP and CT. Then, key trends was calculated by fitting pixel by pixel in region of interest. To quantitatively describe the degree of enhancement, we introduced the Wall Enhancement Index, WEI for short, which was calculated based on pre- and post-contrast VSTAR. In the study, we conducted a Spearman analysis on key trends alongside demographic and clinical indicators. The results revealed that key trends was correlated with IA size and faces score, but there was no correlation between key trends and other demographic and clinical factors. The results of the Spearman analysis are shown in these figures. Figure A and Figure B demonstrate correlations between key trends and faces score and IA size, suggesting that key trends might be a predictive risk factor for non-secular aneurysm rupture. Figure C indicates that there is no correlation between key trends and WEI. Let's focus on the two cases. Case 1 has lower faces score and smaller eye size than case 2. Consequently, the aneurysm in case 1 is lower than case 2 for the rupture risk. Correspondingly, key trends of case 1 is lower than case 2. This further indicates that key trends might serve as a predictive risk factor for non-circular IA rupture. In the two cases, we can see that K-trans appears to exhibit some consistency with WEI. For case 1, K-trans is lower and WEI is lower too. But for the two cases, high aneurysm wall permeability was demonstrated in both cases, but their WEI showed marked differences. Case 1 is higher than case 2. This further demonstrates that there is no correlation between K-trans and enhancement of the aneurysm wall. In our study, we found that IA wall permeability was significantly correlated with IA size and VC score, indicating that K-trans might be a risk indicator for non-circular IA rupture. We also found that K-trans and WEI were not well correlated, which aligned with our expectations as K-trans was calculated outside the vessel wall. It suggests that K-trans might provide new information other than WEI. In the future, we will use a larger sample size to make the experimental conclusions more persuasive. What's more, we plan to conduct longitudinal study to investigate the value of K-trans in non-circular IA rupture prediction. Finally, I would like to thank to all the CBR members. That's all. Thank you.
Thank you so much. It's a great time. Yeah, keep the time just on time. So right now, abstract open to the questions. Their audience. Yeah, I do have a question. Can you just go to the... So I know you showed the K-trans and now they're associated with vessel wall enhancement.
Yeah.
So you mentioned the K-trans was measured outside the wall.
Yeah.
So this is for non-circular. So for circular, you see the association?
Our study showed that for non-circular aneurysm, we found that K-trans was correlated with IA size and VC score. Though previous study found that K-trans was correlated with these two parameters, but their study always focused on circular. But we can see that the structure and shape of circular and non-circular IAs were significantly different. So this conclusion may not be true for non-circular IAs. So our study focused on the non-circular IAs. Thank you.
Yeah, so another question is, it's quite challenging, for the reproducibility about how to correlate, like vessel wall of the aneurysm is quite thin, and how do you do the measurements for the contrast enhancement?
Sorry?
For the wall enhancement of the aneurysm wall, what's the reliability and what's your experience?
By manually delineated the ROI of the wall enhancement, we calculated the wall enhancement index, and we by fitting pixel by pixel, we can calculate the wall enhancement of the vessel wall. This is our experiment.
Okay, thank you so much.
Thank you.
Yeah.
Thank you for your questions.
So now we move to another abstract. It's presented by Dr. Jiayuan Hu. The title is Effect of Statins on Different